Helen, who is
Right.
from 25% ME
So,
group, is going to talk about ME, chronic fatigue syndrome. I'm really interested in this.
Thank you.
Over to you.
Firstly, I would like to thank Leslie especially and the Malnutrition Task Force for organising this sharing practice day to day. I'm Helen Baxter and I'm an advocacy worker specialising in health and social care at 25% ME Group. We're a national charity which supports people with severe and very severe ME, and I have a particular interest in malnutrition and tube feeding. Myalgic encephalomyelitis, chronic fatigue syndrome, ME/CFS, is defined as a neurological illness by the World Health Organization. It affects approximately 250,000 people in the UK. An estimated 25% have severe or very severe ME/CFS and are housebound or bedbound. Some of the most severely affected will require tube feeding. Very little demographic data has been collected on ME/CFS patients, so it is not known how many of these patients are older. However, as patients typically develop ME/CFS as teenagers or young adults, and there isn't a cure, many patients have been ill for decades, with some being severely affected from childhood through to older age. For those ME/CFS patients who are older, comorbidities associated with old age, such as heart disease, further contribute to the disease burden. Malnutrition impacts overall health, in particular wound healing, and that is a concern amongst those who are bedbound. Many severely affected patients develop osteoporosis in their 30s as a result of being non-weight bearing. However, treatment and a good diet for the rest of their life can ameliorate the disease. The cost of living crisis this winter is proving particularly worrying for people with severe ME/CFS, as, in common with older, frail adults, they will have higher fuel bills, including higher electricity bills, because of using medical equipment such as hospital beds, and they can't leave the house to make use of the warm spaces in community centres, etc., which have been created to help people reduce their fuel bills and get nourishing hot meals. And as they are housebound, they're also unable to access food banks. For some, it will be a case of choosing between heating their homes and eating. Many older people, and those with mild to moderate ME/CFS, can find making a meal cognitively difficult and exhausting, as ingredients need to be bought, prepared, and cooked. By the time they're ready to eat, the person may be too exhausted. For people with ME/CFS, an added difficulty is that the activity of meal preparation can lead to post-exertional malaise, a feature of ME/CFS where symptoms worsen following an activity, either at the time or with a delayed onset, but lasting for days. NICE Guideline 206, ME/CFS Diagnosis and Management, states that people with severe ME/CFS may have gastrointestinal difficulties, a reduced or inability to swallow, and are unable to eat and digest food easily, and may need support with hydration and nutrition. Also, that people with very severe ME/CFS may need tube feeding. It recommends working with the person and their family or carers to find ways of minimizing complications caused by gastrointestinal problems, such as nausea, changes to appetite, swallowing difficulties, sore throat, or difficulties with buying, preparing, and eating food. Some people with severe ME/CFS are cared for by family who take great effort trying to give them sufficient nutrition and hydration, providing regular small meals, pureeing food, and feeding them. In some cases, despite such dedicated care from families, tube feeding is still needed, as the patient doesn't have the energy to eat and drink sufficiently, or develops dysphagia. These carers all express concerns as to what will happen to their relative when they are no longer able to care for them. Many older people and people with severe ME/CFS are reliant on home care workers to ensure their nutritional needs are met. Like many older people, many people with severe ME/CFS won't have access to the internet, some because they can't afford it, others because they don't know how to use it. In ME/CFS, a further complication is the hypersensitivity to stimuli, which makes using screens very difficult, and for some, impossible. Lack of access to the internet means that such patients are reliant on other people to do their shopping. A reduction in social care in the UK means it is becoming increasingly difficult to have a shopping call as part of a care package. Many ME/CFS patients find they develop intolerances to certain foods, such as wheat, as well as to preservatives. These cause gastrointestinal problems. To avoid malnutrition, these patients need meals cooked from scratch using fresh ingredients. So care calls need to reflect the time needed to do this. Some patients may need food pureeing, other patients may need feeding. As Hunsbury-Letts points out, this is a very time-consuming process, and it's very costly for adult social care. Many older people take medications, some of which need to be timed around food when food is to be eaten. Some need to be taken at regular intervals during the day, with food, others leaving time before eating. For some ME/CFS patients, their gastrointestinal problems can be caused by mast cell activation disorder, which is treatable with sodium croglycamate and famotidine. However, these drugs need to be given 30 minutes before food or they fail to treat the condition. Like frail older adults, many severe ME/CFS patients require home care workers to prompt and assist them to take their medication. Without treatment, mast cell activation disorder leads to a very significant weight loss and malnutrition. As with elderly, frail adults, it can be more difficult to screen very severely affected ME/CFS patients for malnutrition, as they are bedbound and cannot stand to be weighed. And in the case of ME/CFS patients, they cannot tolerate being hoisted to be weighed. In these instances, it's necessary to take a different approach to assess nutritional risk. To look for visual evidence of weight loss, for example, clothes being looser, find out what the person's dietary intake has been over the last 3 to 6 months, and whether they have experienced problems such as dysphagia. A mid-upper arm circumference measurement gives the clinician an estimated BMI category. A MUAC of less than 23.5 centimeters would indicate the patient is underweight. Taking regular MUAC readings will help identify weight loss and ensure prompt action can be taken, such as fortifying food or prescribing oral nutritional supplements. A case study illustrates some of the problems. This is a lady in her 70s who has had very severe ME/CFS for 25 years. She doesn't have any family locally, and she's 95% bedbound. Approximately 6 years ago, after a change in her circumstances, she needed a package of care. She was reliant on carers to buy food, as she's unable to use the internet. The carers did not have sufficient time within the care call to prepare her a hot meal, and there wasn't a Meals on Wheels service in the area, so she started to buy ready meals for the carer to microwave. These caused gastrointestinal problems. She had frequent daily bouts of diarrhea and began losing weight. Her GP prescribed 2 oral nutritional supplements a day, and a referral was made to the dietetic service. She was able to weigh herself, and at this point weighed 42 kilograms, giving her a BMI of 17. The dietitian assessed her over the phone. This lady finds speech very difficult. The dietitian then posted the Eat Well with a Small Appetite leaflet, which she was unable to read and didn't have anyone to help her read it. Her weight continued to drop, and she was prescribed collagen shots. Weighing only 35 kilograms, she was admitted to hospital for nasogastric tube feeding. During her 2-week admission, she gained some weight, but was still significantly underweight. The situation around meals was not resolved prior to discharge, so she went home and continued on 2 oral nutritional supplements a day and cakes. It was only during lockdown that a local cafe started making food and delivering hot meals to vulnerable people. She really enjoyed the food and described it as flavoursome. With these nutritious meals, she's been able to increase her weight. In 2013, The Guardian reported on a roundtable discussion on malnutrition, where it was said, 15-minute-long visits by domestic carers to older people in their homes may be too brief to let the carer find out why someone is not eating properly, so an opportunity to get to the bottom of a problem is lost. We need to ask ourselves what a carer would be able to do in only 15 minutes to enable someone to eat a nutritious meal. There simply isn't time. As the case study showed, the person became severely malnourished as there was insufficient time for the carer to cook a nutritious meal. For some ME/CFS patients, sheer debility or dysphagia means regardless of the support put in place, they cannot meet their nutritional requirements or get adequate hydration, and they do need tube feeding. Often clinicians are unaware that severe ME/CFS can cause nutritional difficulties. Patients are allowed to become malnourished to a life-threatening degree, and even when hospitalized, enteral feeding is not promptly started. Clinicians do not appear to refer to NICE Guidelines 206 or 32. To avoid malnutrition and the associated consequences, such as the risk of refeeding syndrome, healthcare professionals need to listen to the patient and their family or carers and refer to a nutrition support team who can arrange enteral feeding. Early intervention tube feeding has shown to be beneficial. ME/CFS patients will need a quiet, dark side room in hospital as they are unable to tolerate stimuli, so a planned hospital admission is needed, with discharge home supported by a home enteral nutrition dietitian. To conclude, given the evidence of the problem of malnutrition in chronic disease across all age ranges, we should be able to recognise at an early stage who are at-risk patients to ensure appropriate and timely screening and intervention. Malnutrition in patients with very severe ME/CFS can be avoided with appropriate social care support around meal preparations and, when necessary, early intervention tube feeding. The inclusion of severe ME/CFS in nutritional guidelines would bring about recognition of the condition, helping to ensure a proactive approach is taken. I'm delighted to announce that today, to mark Malnutrition Awareness Week, we are launching an End Malnutrition in ME campaign. Family or carers, and refer to a nutrition support team who can arrange enteral feeding. Early intervention tube feeding has shown to be beneficial. ME/CFS patients will need a quiet, dark side room in hospital as they are unable to tolerate stimuli, so a planned hospital admission is needed, with discharge home supported by a home enteral nutrition dietitian. To conclude, given the evidence of the problem of malnutrition